Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, we're in session number 6, our final session of our current program entitled Permanent Impairments of the Tendinopathies. And in our last session, we talked about permanent impairment options available to the evaluating physician to provide for permanent impairment ratings for examinees who present with lateral epicondylitis and upper extremity tendinopathy. Prior to that session, we spent great time talking about the same topic related to the shoulder. In other words, how to provide for permanent impairment ratings for examinees who have chronic shoulder tendinopathies. And I hope through the course of this series, and especially those last 2 sessions, you start to accelerate your thinking and turn your attention more towards the ever-present tendinopathies that are present in our examinees. You know, the AMA guides don't specifically talk much about the tendinopathies. In fact, they make only brief mention of tendinitis in chapter 16 of the guides. But examinees are presenting with these soft tissue, these painful soft tissue conditions all the time. So if you'll just expand your consciousness and start looking for tendinopathies in your examinees, you're going to find them. And you're going to find that you can provide for additional permanent impairment ratings on top of and in addition to the permanent impairment ratings that you may already have related to loss of range of motion, perhaps related to surgical arthroplasty, and all of the other impairments that are described under the strict application of the AMA guides. You can, in addition to those, you can add on additional impairment due to the disabling effects of the various tendinopathies. And we spent great time in our last 2 sessions talking about just how to do that in relation to the shoulder and the elbow tendinopathies. Now in today's session, I want to conclude our series by just giving you some additional ideas that you can use and that you can employ to provide for permanent impairments for your examinees who have now lower extremity tendinopathies. And we'll talk today about patellar tendinopathy and also about Achilles tendinopathy. Now, these are not the only tendinopathies in the lower extremities. We also have gluteus medius tendinopathy, we have adductor tendinopathy, we have plantar fasciitis, which is a common form of tendinopathy seen in the industrial setting. But we're going to use patellar tendinopathy and Achilles tendinopathy as our template tendinopathies to talk about some of the permanent impairment options that you have available to you under both the strict application of the AMA guides and then also alternatively under Almarez and Guzman. So before we get into the permanent impairment options, let's just go over a couple of the risk factors and interesting facts regarding patellar and Achilles tendinopathies. Okay, so with regards to patellar tendinopathy, I have a couple of things to share with you. From a recent study from the Asia Pacific Journal of Sports Medicine, and the Asia Pacific Journal of Sports Medicine tells us a few things about patellar tendinopathy, sometimes referred to also as jumper's knee, that we already knew about or that we already know about regarding other tendinopathies as well. But they describe 4 stages in the development of jumper's knee. The first stage is pain after work activity. And you may be familiar with this yourself, and you may hear your injured workers talk about how they begin their work day or they begin their work week feeling fine, and they commence their work activities and they proceed the entire day throughout the course of their work activities with no sensation of pain at all in the knees. However, later in the day or the next day, they notice that their knees are what they would refer to as sore or stiff or tight or achy, and they have pain not during work activity, but pain that shows up after the work activity. So this is the first stage. The next stage is pain that presents itself during activity but does not cause limitation in the performance of the said activity, whatever that activity may be. Now, some authors describe a substage prior to this stage. They talk about pain that occurs during activity, but that resolves with warm-up. So as the employee begins his activities, he may notice pain and stiffness and aching, but as he gets going, that pain seems to resolve and work itself out and doesn't cause any limitation in the performance of the activity. Well, in this study, they talk about a slightly more advanced stage where the examinee or the employee has pain during the activity. In other words, he's constantly aware of pain and stiffness and aching in his knees, and yet he's still able to perform all of the activities that are required of him throughout the course of his day. Well, as the tendinopathy and the degeneration in the tendon worsens, the employee will complain of pain during or after activity, but now the employee is starting to make modifications to the performance of their activities because the pain is starting to interfere with normal function, and the pain is starting to cause some limitations in bending, in climbing, in squatting, in climbing ladders, in going down hills. Is causing some sort of disturbance in normal function, which manifests itself in visible outward pain behaviors that can be observed by an outside examiner or an outside observer. Well, when the tendinopathy condition continues to degenerate and continues to be ignored by the employee, and continued loading is placed upon the tendon may eventually give up the fight and will eventually undergo rupture. And this is the fourth stage in the progressive degenerative process. Now, of course, we want to be able to interrupt this progressive degenerative process before the ultimate end stage, which is patellar rupture. And the theory of the degenerative tendinopathy model is that excessive mechanical loading causes catabolic changes in the tendons. Well, what are some of those catabolic changes? Well, the most important of which seems to involve differentiation of tendon stem cells into non-tendon cells. So we have the conversion of normal tenocytes, tendon cells, which are responsible for the production of normal healthy tendon, into non-tenocytes. Well, some of the cell types that have been found in degenerative tendinopathy tendon include chondrocytes, cartilage-producing cells, include adipocytes, fat-producing cells, leading to fatty degenerative changes of the tendon. Also fibrocytes, fibrous connective tissue producing cell types in degenerative tendinopathy tendon. So we see the differentiation of normal healthy tendon stem cells into some other form of connective tissue stem cell, including cartilage cells, fat cells, and fibrocyte cells. Well, none of those alternative cells are responsible for producing healthy tendon matrix, and so we see the production of cartilage-based matrix, or fat-based matrix, or fibrous connective tissue-based matrix, which is a whole different animal from normal healthy tendinous matrix. And these degenerative tendons become painful. Now, macroscopically, healthy tendon is not a neural structure. However, during degeneration, innervation to the tendon increases. We see this microscopically under the microscope. And we know that chronic degenerative tendon is painful, but it's not sure and it's not well elucidated what exactly is the cause of the pain in degenerative tendinopathy. We know that degenerative tendons are painful, but we don't know the cause or the source of the pain. Some authors have postulated that it has to do with innervation by free nerve endings, that it has to do with the release of pain mediators such as leukotrienes and cytokines, and pH changes within the interior matrix of the tendon. But as yet, no certain etiology of the pain has been clearly elucidated. We simply know that degenerative tendons are indeed painful. And so with patellar tendinopathy, we see that excessive mechanical loading leads to the development of the degenerative process. And this is not unlike, or this is not dissimilar to tendinopathies in other parts of the body, where excessive mechanical loading seems to upset the cellular homeostasis of the tenocytes and the tendinous matrix, and somehow, some way leads to an increase in catabolism within the tendon compared to the rate of anabolism, or building up of the tendon tissue. Well, in a new study in 2016 published in the International Journal of Sports Physical Therapy, they reiterate some of these same findings now with relationship to Achilles tendinopathy. They tell us, and this will apply to many of the other tendinopathies as well, that Achilles tendinopathies affect about 2% of the general population, and only 35% of the cases presenting to the general practitioners are linked to sports participation, and therefore that leaves the possibility open that many of these cases presenting to general practitioners are due to excessive loading in the industrial setting. And the risk factors for the development of Achilles tendinopathy separate themselves into two groups. Those factors that seem to increase the wear and tear, in other words, that contribute to excessive and prolonged loading on the tendon. These are the weight-bearing loads assumed by the tendon, compared to those factors that limit the normal repair process, such as diabetes. And it seems that it's the complex interplay between these two forces, these anabolic and catabolic forces, that tip the delicate balance between healthy tendon and degenerative tendon. These factors that increase wear and tear on the tendon are the so-called extrinsic risk factors. Factors that limit the repair capacity and potential of the tendon are referred to as intrinsic risk factors. Those are risk factors that are specific to the employee, whereas extrinsic risk factors are non-specific or are external to the employee. So let's talk about some of these extrinsic and intrinsic risk factors. Well, sudden changes in loading seem to be a primary risk factor that increase the wear and tear on the tendon. And you'll hear employees talk about how they were assigned new job duties, or they were assigned duties at a new job location, perhaps some new location involved walking up and down hills, whereas customarily their job duties involve simply navigating flat surfaces. Now they're required to go specifically up and down hills, and it's this new change in the loading pattern and the loading volume on the tendon that causes a disruption in the normal homeostasis between wear and tear and repair of the tendon. And this is just the type of thing that can initiate the new onset of painful symptoms. A change in the work surface, whereas before the employee had a soft and forgiving work surface, perhaps working on a rubber or a mat, now working on a concrete and an unforgiving hard surface, such as in a warehouse, such as at the Costco or Sam's Club warehouses. Also, footwear, such as wearing flat shoes and orthotics, or poorly supportive footwear that doesn't provide normal biomechanics for the foot. Perhaps the examinee or the employee just purchased a new set of boots that have caused an upset in the normal biomechanics that the employee has been otherwise accustomed to. And it's this type of thing, this type of a change, that can cause a disruption in the normal homeostasis and tip the delicate balance of the tendon into a degenerative, painful type of condition. Intrinsic risk factors, on the other hand, are those risk factors that are unique to the individual that seem to thwart or inhibit the normal repair process. The number one risk factor that limits the normal repair process, of course, is advancing age. And we talked in earlier programs about how, at least as regards the shoulder tendinopathy seems to be an age-related degenerative process, because even in asymptomatic shoulders, we see through MRI, we see the presence of micro tears and changes, histologic changes in normal healthy tendons in and around the shoulder, even in asymptomatic individuals. It's not uncommon to see rotator cuff partial substance tears, bicep tendon partial substance tears, even in individuals who do not complain of shoulder pain or shoulder limitations. So advancing age is primary risk factor. Obesity and other diseases of lifestyle, such as hypercholesterolemia and type 2 diabetes, seem to inhibit the delicate balance between tendon homeostasis. Recent injuries, including previous limb tendinopathies, any type of tendinopathy in the lower extremity, can affect the Achilles tendon and make it difficult for the Achilles tendon to repair itself. Gender, it seems that Achilles tendinopathy is much more common in males than females. And this is unique to Achilles tendinopathy because some tendinopathies have equal prevalence between the sexes, and some tendinopathies, such as gluteus medius tendinopathy, are more commonly found in the female gender. Also, exposure to some chemicals, such as steroids and antibiotics, seem to negatively affect tendon homeostasis. And then, in addition, as an intrinsic risk factor, ankle stiffness, such as reduced ankle dorsiflexion, seems to be a universal intrinsic risk factor for many lower extremity conditions, and especially and specifically as relates to this program, specifically seems to be a contributing factor to the development of Achilles tendinopathy. So when we have an examinee present with either Achilles tendinopathy or Patellar tendinopathy, and it seems that the condition is at maximum medical improvement, but the examinee is still reporting symptoms and activity limitations, what are the permanent impairment options that are available to us as qualified medical evaluators to accurately rate the impairment? Well, we're going to go over several of those now, and this is not a complete list. And before we do that, I just want you to know that both the AMA guides and Almarez and Guzman provide us as qualified medical evaluators with great latitude and great liberty in providing for permanent impairment ratings. So really, you are not limited. In fact, you're unlimited in the types and descriptions of permanent impairment ratings that you can provide for these examinees. The only thing that's required of you is that you adequately explain how, whatever permanent impairment rating you're providing for the examinee, you have to be able to explain how and why that permanent impairment rating is the most accurate rating. Okay, so whether you're providing for a permanent impairment rating under the strict application of the AMA guides, or whether you're providing a permanent impairment rating under Almarez and Guzman, all you have to do is simply pick an impairment from within the four corners of the AMA guides and explain to the parties why your particular description of the impairment is the most accurate description of the examinee's true impairment. So for patellar tendinopathy, one of the impairment options that we have available to us is related to patellar instability. Patellar instability. So in table 1733 of the AMA guides, they talk about patellar subluxation or dislocation with residual instability. Well, we know that chronic degenerative patellar tendon is a loose tendon, is a sloppy tendon, is a tendon that fails to be able to resist tensile linear stresses and tensile loading. So over time, that's a tendon that's going to undergo elongation, which is also referred to as creep, C-R-E-E-P. So as tendons stretch, they undergo stretch through a process referred to as creep. Well, with chronic degenerative patellar tendinopathy, the patellar tendon becomes lengthened and can contribute to loosening or dislocation or residual instability of the patella within the trochlear groove of the femur. And many times you can confirm this on physical examination by using the patellar apprehension maneuver, and also on radiographic studies which demonstrate the presence of what's referred to as patella alta. Patella alta. Patella alta is a high riding patella within the trochlear groove, and patella alta is determined by measuring and calculating the insole ratio. The insole ratio, and the insole ratio is simply a description of the ratio between the length of the patella, which is measured from the superior to the inferior pole of the patella, compared to the length of the patellar tendon. And with patellar tendinopathy, we see an elongation of the patellar tendon so that the length of the patellar tendon greatly exceeds the length of the patella, thereby increasing the insole ratio. So patella alta is a radiographic finding for patellar tendinopathy. And once you identify patellar tendinopathy either through physical examination and or through radiographic examination, you can then use table 1733 to provide for 3% whole person impairment due to patellar instability. So that's one option that you have available in those examinees that have patellar tendinopathy. Another option that you have available to you has to do with permanent impairment related to loss of strength as assessed by manual muscle testing. So here in table 17.8, we have impairment values due to loss of strength, and in this case it's going to be due to loss of strength of resisted knee extension. Now, with patellar tendinopathy cases, it's going to be a rare case where you're able to identify loss of quadriceps strength through manual muscle testing. Quadriceps are simply too strong to be able to pick up subtle weaknesses due to patellar tendinopathy. So for that reason, the best way to assess for loss of strength of resisted knee extension is through the repetitive squat maneuver. And examinees who have to move their body weight through repetitive squatting, such as 5, 8, or 10 repetitions of repetitive squatting, will report pain and will report weakness in the affected patellar tendon. And of course, they should point to the patellar tendon, and their complaints of pain should be consistent with patellar tendinopathy. And if you're convinced that their strength is indeed limited as a result of patellar tendinopathy, then you can provide for permanent impairment, typically due to grade 4 loss of strength of resisted knee extension. So here the AMA guides provide for 5% whole person impairment due to simply a grade 4 loss of strength of resisted knee extension, with increasing to 7% for a grade 3 and even 10% for grade 2. So always perform the repetitive squat maneuver with your examinees who report to you knee pain because loss of strength of resisted repetitive squatting qualifies for permanent impairment. And this is something that you can easily identify through the repetitive squat maneuver that might otherwise be difficult to identify through manual muscle testing procedures. In addition to patellar instability and loss of muscle strength, the patellar tendinopathy conditions may also qualify for impairment due to another sign of loss of muscle function, which is measured atrophy of the involved quadriceps. So over time, with chronic patellar tendinopathy, the examinee or the employee is going to self-limit the number of repetitions and the amount of loading that they apply to the affected patellar tendon. And over time, this is going to cause atrophy of the affected quadriceps muscle. So when you are able to identify atrophy of the quadriceps muscle, then Table 17.6 provides for permanent impairment ratings due to loss of size of the quadriceps muscles. So impairment values for muscle atrophy range from 1 to 2% whole person to as high as 5% whole person impairment in those cases where the thigh is atrophied 3 centimeters or more. Remember, 1 inch is 2.5 centimeters. So this is really not a lot of atrophy. This can easily be picked up in a large male worker. 3 centimeters of atrophy is not unusual for a large male, and this qualifies as a severe atrophy impairment at 5% whole person impairment. So there's a couple of ideas for you with regards to patellar tendinopathy. And according to the cross usage chart, these findings for loss of muscle function, such as atrophy and loss of strength to manual muscle testing, these cannot be combined. However, under Almarez and Guzman, you can combine them in any combination and any order that you want, as long as you're able to explain convincingly and with substantial medical evidence how and why your permanent impairment rating, even if it deviates from the impairment rating under the strict application of the AMA guides, as long as you provide a compelling argument as to how and why your impairment rating is more accurate and is the most accurate rating, then the rating will be upheld by the parties. Now, with regards to Achilles tendinopathy, most commonly your impairment ratings due to chronic Achilles tendinopathy are going to involve impairment ratings associated with gait disturbance. And I have a couple of ideas to share with you regarding that. So, Table 17.5 in the AMA guides, this is in the lower extremity chapter, talks about lower limb impairments due to gait derangement. Now, typically with chronic Achilles tendinopathy, and even following surgical repair of a ruptured Achilles tendon, the examinee is going to have an antalgic limp with a shortened stance phase. And the stance phase becomes shortened in the late aspect of the stance phase as the examinee self-limits ankle dorsiflexion in order to minimize loading on that painful Achilles tendon. So this will manifest itself as an antalgic limp with a shortened stance phase. And I'm thinking of a guy at my gym who actually ruptured his Achilles tendon and had his Achilles tendon repaired, and it left him with a disastrous limp, and it left him with significant atrophy of his otherwise previously bulbous and muscular calf. And it's a terrible impairment. So the standard impairment that applies to this case would be 7% whole person due to antalgic limp, but may even progress to higher impairment values if the examinee requires part-time use of a cane or a crutch for distance walking, but not usually at home or in the workplace. And this is a common impairment. Examinees will tell you that they use a cane or a crutch when they go out of their house, such as when they go shopping, such as when they go to the flea market, but generally not at home. So with these types of examinees, all you need is some sort of objective verification, such as a photo or such as an actual cane or a crutch that they bring to the evaluation meeting, face-to-face meeting with you. Some type of objective verification that they do indeed use a cane or that they do indeed use a crutch part-time would be sufficient for you to provide for them a much higher permanent impairment rating, in this case as high as 15% whole person. Now, in cases where the examinee requires a short leg brace to protect the ankle and to protect the Achilles tendon, permanent impairment ratings could even increase up into the 20 and 30%. But generally, with standard Achilles tendinopathies, you'll be involving yourself with somewhere within the range of 7 to 15% whole person. And this is under the strict application of the AMA guides right out of Chapter 17, Table 17-5. Now, because of some limitations in Chapter 17 and limitations with the strict application of the AMA guides that prevent evaluators from combining impairments with due to gait disturbance with other impairments, such as loss of range of motion, such as loss of muscle strength, such as atrophy, some examiners prefer to escape Chapter 17 and escape the permanent impairment rating due to gait disturbance in Chapter 17 and instead use impairments due to station and gait disorders out of Chapter 13, because that then allows them to employ impairment due to gait disturbance without being restricted and without being limited in combining other impairments in Chapter 17 under the strict application of the AMA guides. So you may find that with your particular employee or examinee, that providing for permanent impairment due to gait derangement out of Chapter 13 allows you to more accurately describe the totality of their impairments by employing impairments due to gait as well as some of the other impairments described in Chapter 17 that otherwise could not be combined due to limitations described in the cross usage chart, which is Table 17.2. So this is might be a little bit difficult to read, but Table 1315 provides for Class 1, Class 2, Class 3, and Class 4 impairments. Most of the impairments will be described adequately in Class 1, which describes an examinee who rises to a standing position, who walks, but who describes some difficulty to you in walking up elevations due to pain in the Achilles tendon, pain walking up grades, pain walking up stairs, and pain with walking long distances. Now, highlighted here in yellow are those objective findings that you're going to be able to observe in the face-to-face evaluation. In other words, you can observe the examinee to rise to a standing position. You can observe the examinee to be able to walk. You can observe the examinee to be able to arise from a deep chair. But you're going to be required to rely on the examinee's own descriptions of their difficulty with elevations, their difficulty with grades, and their difficulty with stairs. In those examinees who you're convinced do have such difficulties, you can provide as much as 9% whole person impairment out of Chapter 13 and thereby escape the limitations inherent within Chapter 17. For a Class 2 impairment, this is an examinee who can rise to a standing position, who can walk some distance with difficulty and without assistance, but is limited to level surfaces. Now, this perfectly describes an examinee with Achilles tendinopathy because we know it's the inclined surfaces that contribute to the development of Achilles tendinopathy, that contribute to the excessive loading of the Achilles tendon, and that contribute to the painful symptoms of the condition. So these examinees are pretty much limited to level surfaces. Well, look at the impairment rating here, 10 to 19% whole person, significantly higher than those impairment ratings provided for in Chapter 17, and also without the inherent limitations that restrict these impairments from being combined with other impairments according to the cross-usage chart. And then also we have the Class 3 impairments, which describe an examinee who rises and maintains a standing position with difficulty, but cannot walk without assistance, such as perhaps through an ankle-foot orthosis, or perhaps without a cane or a crutch. And then finally, the Class 4 impairment, which generally will not apply to Achilles tendinopathy cases. These are examinees who cannot stand without help, without mechanical support, and or without an assistive device. So these generally won't apply to Achilles tendinopathy cases, but certainly your impairments Class 1 through Class 3 could apply and may provide the most accurate description of the gait disturbance that your examinee presents with. And this may be an attractive option for you because it allows you to escape Chapter 17. And then similar to our patellar tendinopathy cases, our Achilles tendinopathy cases will also qualify for permanent impairment due to atrophy and also due to loss of muscle strength. And as I said, there's a guy in my gym who ruptured his Achilles tendon and then subsequently had another injury where he suffered a burst fracture to the calcaneus on the same side as the ruptured Achilles tendon. But even before he suffered the burst fracture of the calcaneus, I was able to easily identify atrophy in his calf muscle following the surgical repair of the Achilles tendon. So in these examinees, the AMA guides provide for permanent impairment due to loss of circumference of the calf muscle. And impairment ratings, similar to the impairment ratings for loss of circumference of the quadriceps, the impairment ratings range from 0 to 5% whole person impairment based upon the extent of the atrophy of the calf muscles. So it doesn't take long for this atrophy to set in, and so simply make sure that the examinee is at maximum medical improvement before you obtain the measurement. And if you're not convinced that the calf muscle has reached its maximum atrophy, in other words, if you suspect that additional atrophy is going to occur, you may decide to wait to declare the examinee permanent and stationary until an adequate time following, say, for example, surgical repair. It may take as much as a year for maximum atrophy to set in. So if the examinee is not, in your opinion, at maximum atrophy, you may decide to hold off on the permanent and stationary declaration to allow adequate time for maximum atrophy to demonstrate itself in the examinee, thereby qualifying them for the highest impairment value. And then finally, another impairment option for you is to provide for permanent impairment under Table 17.8 due to loss of strength of ankle, typically will be ankle plantar flexion. So we test resisted ankle plantar flexion by having the examinee do repetitive heel raises. In other words, loss of strength of ankle plantar flexion is difficult to identify by standard resisted manual muscle testing. The gastrocnemius and soleus muscle complex is simply too strong, even in a tendinopathy condition, for you to be able to pick up subtle losses of strength. So for that reason, we have the examinee use a heavier load, such as their body weight, by performing repetitive heel raises. And over the course of 10, 15, 20 repetitive heel raises, that weakness will manifest itself typically as a grade 4 or perhaps even as a grade 3 loss of strength. So grade 4 representing approximately 25% loss of strength, grade 3 representing as much as 50% loss of strength, qualifies for 7% whole person impairment in the case of a grade 4 muscle strength grading, and as high as 10% in a grade 3 muscle strength grading. So you can use these permanent impairment ratings in any combination that you feel appropriate under Almarez and Guzman, as long as you explain how and why these impairments should be added or can be combined, even in contradiction to the cross-usage chart. As long as you provide adequate explanation as to how and why your permanent impairment rating is the most accurate rating, then the impairment rating will be upheld. So, as I said earlier, many examiners like to escape the constraints of the cross-usage chart by going to other chapters in the AMA guide, such as Chapter 13, to incorporate some of those other impairment ratings that otherwise escape the constraints of the cross-usage chart. So doctors, there's some ideas for you with regards to patellar and Achilles tendinopathies. The other tendinopathies of the lower extremities, such as gluteus medius tendinopathy, such as adductor tendinopathy, such as plantar fasciitis, which is a form of tendinopathy. These can all be rated similarly by assessing the impact of those conditions on gait, by assessing the impact of those conditions on muscle strength, and by assessing those conditions on the muscle function as evidenced in the circumference and girth of the involved muscle. So really, we're not limited and we're not constrained by Chapter 17. We can go anywhere within the four corners of the AMA guides as long as our reasoning is sound. So doctors, I hope this helps you. I hope this gives you some ideas that you can employ in providing for permanent impairment ratings for your examinees who have lower extremity tendinopathies. Lower extremity tendinopathies are not in any way limited to patellar tendinopathies or Achilles tendinopathies, but we simply use those two examples as templates for some of the different options that you have available to rate those cases that involve lower extremity tendinopathies. And before we conclude this program, I just want to remind you that as we encounter an aging population, and as we encounter employees who are involved in repetitive and cumulative stress job place duties, we're going to be seeing examinees who have these tendinopathy conditions. But many times, these tendinopathy conditions are not recognized for what they are. We diagnose these conditions as other repetitive stress conditions, and when it comes time to provide for permanent impairment ratings, we overlook some of these complementary permanent impairment ratings that we could employ to describe the impact of these tendinopathy conditions on the examinee's ability to function in both work and daily living activities. So I want to encourage you to start thinking about tendinopathies and identifying the tendinopathies that are already present in your population of examinees. As we talked about in some of the earlier sessions of this program, the tendons of the body are very delicately balanced structures. When we're young, they seem to be fine, and they seem to be able to handle the muscular forces that the muscles place upon these tendons in connecting the tendons to the bones. But as repetitive stresses and years accumulate, it seems that somehow, and the exact mechanism isn't clearly understood, or maybe I should better phrase it by stating that through the research that I've done, I still don't fully understand the mechanism whereby healthy tendons undergo or begin to undergo the degenerative process. I don't think it's fully understood in the literature yet, but somehow the normal homeostasis of the tendon becomes disrupted as the amount of loading that the tendon is exposed to exceeds the rate at which the tendon can repair itself. And it seems degenerative tendinopathy involves some upset in three basic structures. It involves some upset in the tendon cells themselves, the tenocytes themselves, where the tenocytes undergo some degenerative changes. Number two, there's some upset in the content and the quality of the collagen fibers associated with the tendon in the matrix of the tendon. And then number three, the extracellular matrix, which is scant in tendons anyway, but the extracellular matrix seems to undergo some upset in some decay and some degenerative process where the extracellular matrix becomes replaced with poor quality and degenerative tissue, including in some cases and in some reports cartilage tissue. In some cases and some reports describe replacement by fatty tissue. And some cases and some reports describe replacement of the extracellular matrix with some sort of fibrous or scar tissue-like matrix. So the whole kit and caboodle of the tendon changes and becomes degenerative and has a totally different appearance under the microscope compared to normal healthy tendon. And in many cases, this degenerative process, if the excessive mechanical loading circumstance and situation isn't discovered and handled properly, if we first don't discover where is the source of the excessive loading, and then number two, if we don't appropriately handle the loading and reduce the loading and change the loading scenario of the tendon, many of these tendinopathy conditions become chronic and become permanent, such that the tendon undergoes degenerative changes and loses function, so that ultimately there's a loss of strength in and around the local joint involved with that tendon. So if we can identify these cases when they present themselves, we can properly provide for permanent impairment ratings for these examinees who have these conditions that likely will never get well, that will never recover to pre-injury condition, that will never return to normal healthy tendon condition. And we do these examinees a great disservice when we fail to identify these conditions and when we fail to properly provide for permanent impairments for these examinees who truly deserve the permanent impairment rating associated with the tendinopathy aspect of their condition. So I hope this helps you, doctors, and I hope this opens up a new realm of thinking for you in your evaluation of our injured workers. So I hope you enjoyed this program. I look forward to being with you on future programs as well. And for now, this is Dr. Perry Carpenter, wishing you best of success in your career as a qualified medical evaluator.